presentation, and I will be talking something on fungal keratitis. This is a long going the same courses, the standard medical therapy, intrastromal and intracameral. So you know that it is mostly from the developing countries, and in the tertiary level we always see more fungal than bacterial. But when you are in a small setup, isolated clinic, that you see a lot of primary cases actually. We see a lot of late cases, and treatment is empirical. And you know that empirical treatment always difficult, and you need more knowledge than if you have microbiology setup. So you must have all the knowledge, how it looks like, what is the difference between, what is the geographical pattern. Like Fusarium, it is predominantly in South India. East India, North India, it is predominantly in Aspergillus. So this knowledge is also important. Again, that farmer, that paddies with an onion, Fusarium is more common with onion cultivating farmer rather than paddy, where the Aspergillus is more common. And everything should be kept in mind before starting empirical treatment. And the sensitive pattern of that particular area. You start empirical treatment, but you see the patient for 48 to 72 hours, then you see the response. If it doesn't, you refer to a colleague who does have microbiology support. So AIOS guideline is there. There are a lot of therapeutic guidelines, so it depends on size, location, depth of infiltration, presence of hypopyon at its amount, and preliminary clinical or KOH mount, which you can do in your clinic, whether KOH is positive or not. These are the list of antifungal drugs, and if you see that there are some eye drop preparation, we have actually 3 eye drops in our country, which is commercially available. We make it actually amphotericin B, but natamycin and voriconazole is commercially available. And we have some oral form is there. Oral form, these are the common oral form use. And if you see the in vitro sensitivity pattern, you see that the sensitivity pattern are different with different antifungal agent, and you have to remember those facts while you prescribing your medicine to those patients. So key points to remember that all antifungals are fungistatic in nature except one, which is not available. Natamycin is the drug of choice for filamentous keratitis, especially Fusarium. Then amphotericin B is effective against Candida and Aspergillus species, and it is not that less effective against Fusarium. And fluconazole showed good activity against Candida. So role of scraping is always there. It is a must for diagnosis, for all the therapeutic, all the microbial load you will be off, and also in some of the cases you have to do repeated scraping, maybe every 3rd day or every 2nd day, depending, but especially with dematicious fungus. So initial management is monotherapy, whether the ulcer is less than 5 millimeter, 1/3 depth of hypopyon and a trace of hypopyon, you can start with monotherapy with natamycin is the drug of choice. And then the protocol is half an hourly, then 1 hourly next day, and depending upon the response you can reduce. Then amphotericin B or voriconazole, then cyclopelgic antibiotic. Review initially on every 2nd or 3rd day, then weekly see the response, and depending upon that and tapering or combination therapy. You have all read this article, Mart trial. They have shown that the topical natamycin is the only drug that should be used alone in case of Fusarium keratitis. Voriconazole should not be used as a monotherapy. And if you see the in vitro susceptibility, again filamentous, from that particular study the results had come up that you can use voriconazole and natamycin in combination, and because they are the 2 different groups, one is polyene, one is azole. Then combination therapy is important for 1/8 person if the ulcer is more than 5 millimeter size, deep ulcer, and there is a lot of hypopyon, scleral involvement, And maybe in some of the cases where it is not responding, then you can start. And you must know that amphotericin B and natamycin are not synergistic because they are in the same class of drug. Then role of systemic antifungal, there are some drugs that they are fluconazole, ketoconazole, itraconazole, voriconazole. Voriconazole is most expensive and a lot of side effects are there, but systemic toxicity you have to keep in mind. Then MART2 trial come, they have shown that topical nata versus topical voriconazole plus minus oral voriconazole, they have shown that oral treatment doesn't increase the rate of perforation. That way, it is not effective as we used to think that it may be more effective. The question is how long is to continue antifungal treatment. That is a little dilemma because we see from size, we cannot see the angle, if especially with filamentous fungus. So rule of thumb is continue when you think that it is healed, continue for another 2 weeks and call the patient and see whether there is any signs of recurrence, and then you can say that, oh yes, ulcer is healed. Then the concept of targeted therapy, role of intracameral and intrastromal, lot of studies have been done and lot of advantages, disadvantages are there. So this is typically for the those cases where epithelium is completely healed, the drug will not penetrate through the epithelium. So you have to just take out the same time you give intracameral and intrastromal antifungal agents. So indication is typically the endothelial exudates or plaque with healed ocular surface and you have recommended doses of all these things are there, and there are a lot of publication, anecdotal reports, and everything are there. Some are saying that it is acting, some are saying it is not acting, but then Namrata's paper came out with ARCT trial, and the paper said that intracameral amphobi doesn't offer any benefit over topical antifungal therapy when performed alone and associated drainage of hypopion. We have some example we had tried earlier. This particular patient actually healed after 14 days and we gave 2 injections of intracameral amphotericin B. Similarly, load of intracameral voriconazole, because of its half-life is less, so it is wise not to use intracameral voriconazole alone. So there are also several anecdotal reports. Some says that it is working, so you have to repeat it actually. So you may combine with intrastromal and intracameral some form either of these 2 drugs, and there are different reports. Intrastromal voriconazole for deep keratitis, ineffectiveness of intrastromal voriconazole for filamentous fungus cases, and then again the study came that intrastromal voriconazole alone did not provide any additional benefit over topical voriconazole. This again, Namrata's group has published this paper. Then combination, as I said, this is our patient, and this particular patient surface was complete, and this patient responded with 2 doses of combination like intracameral ampho-B with intrastromal voriconazole. So summary, you have to take a call, but you might remember that the complication like uveitis, secondary glaucoma, and iris neovascularization happens, and subsequently there are a lot of bleeding happens during therapeutic PK while doing peripheral iridectomy. So these are one case report, and this is after DMEC interface, so you may not have to. These are the ideal cases where you give stab incision, interface wash, and give intrastromal voriconazole. So TST protocol is there. This is again by Namrata Sharma. She has a lot of works on this, and it actually says that there is an algorithm how you will go with it. Beautifully, it is given like that. If you see that topical natamycin alone, then systemic antifungal in some of the cases where ulcer is more than 5 millimeter, depth is more than 50%. You see the response, poor response goes this side, good response, continue treatment. If there is poor response, again therapeutic PK, intrastromal, continue good response, you continue with that combination, either natamycin and voriconazole. And again, if you have poor response, if you go and repeat the intrastromal injection, again ultimately one end is here, therapeutic keratoplasty. So if you have all these combination, depending upon your response, and you can try in your case, it is very nice. So take home message is timely standard medical therapy is the key to success in most of the fungal keratitis. So smaller ulcer, this is monotherapy is good, but natamycin is the drug of choice for fusarium. Amphotericin B may be more effective in aspergillus and candida. Voriconazole is not effective in fusarium. Combination therapy like Pauline and azole may have synergistic action, and intracameral ampho-B may have values in deep keratitis with endoexudates, and intrastromal voriconazole does some role in candida infection but not in filamentous fungi. Thank you very much for your patient hearing.
Thank you so much, sir, for that very comprehensive coverage of fungal keratitis. And I next request Dr. Rajesh Sinha to give his talk on acanthamoeba keratitis. If there are any questions for Dr. Basak, because he has to leave, we can take it up now. No, on fungal keratitis, if you want to ask anything, rest of the questions we can take later.
Prophylactic, that is a big question, and that is actually is tough question. So normal saying heads 6 months, but this 21 patient I reported, many of them are going for 18 months. One patient is going for 2 years. So it may be lifelong. Some of the patient, it may be lifelong. I have discussion with James. He has lot of work with, some of the cases you have to give lifelong. Only you have done a beautiful surgery, and then the problem started. Once recurrence happened, you again treat them with therapeutic doses. Now you have to keep the patients for prophylactic dose for lifelong. So you have to do KFT, LFT and all these parameters, systemic take it. So one valacyclovir, once a day, one of my patient getting for 2.5 years. Nothing happened, but patient graft is doing good. So these are the things. So heads is one thing long time back, but individual patient, you have to take the call, and you have to discuss the patient. You have to come again and again and again, because we do not have other than these two medicine, nothing is there.
Okay, and it's quite safe, I can tell you. Even if you give them, it's very safe drug. Very safe drug. Yeah, yeah. So if you give them lifelong, nothing happens actually. I have patients are going on for 5 years, 6 years, just take it. It's okay.
No. And